Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal. In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy. This episode reviews the article titled Metabolic and Cardiometabolic Changes After Sleeve Gastrectomy in a Patient with Type 1 Diabetes and Morbid Obesity. So, I want you, the listener, to imagine being trapped in this kind of biological paradox.
Right. It's a tough situation to even conceptualize.
Yeah, because the only medicine that keeps you alive is simultaneously causing your body to fail.
Exactly.
So every dose you take to survive today pushes you closer to a catastrophic breakdown tomorrow.
And that is the devastating reality of a condition that's becoming known as double diabetes.
Right. And in today's deep dive, we're exploring a March 2026 case report where doctors take a surgical approach, usually meant for type 2 diabetes, and they apply it to a type 1 patient.
Which is largely unmapped territory. The paper is a care-compliant case report, and to put it in perspective, metabolic surgery for type 1 is just not standard practice.
Because the established literature mostly focuses on type 2, right?
Exactly. For type 2, these procedures are a gold standard. But for type 1, the evidence is this fractured mix of small, highly variable studies.
Right, which makes a rigorously documented report like this so crucial. It's a real puzzle piece for the medical community.
It absolutely is.
So I'm struggling a bit to picture how these two diseases overlap. I mean, growing up, the cultural image of a type 1 diabetic was someone who was struggling to keep weight on.
That's very true.
Unexplained weight loss was like the classic warning sign. Are we seeing a complete demographic shift here?
We really are looking at a profound shift, yes. Historically, the onset of type 1 is characterized by rapid weight loss.
Because the body can't use glucose, so it just burns through fat and muscle.
Right, exactly. But modern demographics show that the prevalence of overweight and obesity in individuals with type 1 is rising right alongside the general population.
Wow, okay. So when those factors collide, it creates this vicious trap.
It does. It creates a unique metabolic trap that is very hard to break out of.
Let's run with an analogy here because I think it helps visualize the mechanics. Tell me if this works.
Okay, let's hear it.
With type 1 diabetes, the pancreas is like broken hardware. The physical machinery just shuts down and makes zero insulin.
Spot on. The physical machinery is broken.
But with type 2 diabetes, it's more of a software glitch. The pancreas might still churn out insulin, but the body's cells aren't reading the code correctly.
Yeah, they become resistant, usually due to lifestyle, diet, or weight factors.
So in a double diabetes scenario, are we looking at a system suffering from a hardware failure and a software crash at the exact same time?
That is a highly effective way to frame it. I really like that analogy. The hardware produces no endogenous insulin.
Right.
So that forces the patient to rely entirely on exogenous or injected insulin.
Okay.
But because of the obesity, the software is glitching. Their tissues are actively resisting that injected insulin. And this is where the biological trap snaps shut.
How so?
Well, insulin is an anabolic hormone. Its primary evolutionary function is to promote the storage of energy, largely as fat.
Oh, wow. So if your cells are resisting the insulin, you have to inject larger and larger doses, right, just to manage your baseline blood sugar.
Exactly. But those massive doses of insulin are simultaneously signaling your body to store more fat.
Which just drives the weight up even further.
Yes, which deepens the insulin resistance.
Which means you need even more insulin.
You see how it works? It is an accelerating cycle. And the source material emphasizes that this doesn't just impact weight.
Right, it layers on all these other risks.
Exactly. This combination layers the profound inflammatory and cardiovascular stresses of morbid obesity right on top of the standard complications of type 1 diabetes.
So we are talking about heavily elevated cardiometabolic risk markers.
Yeah, a significantly higher risk for heart attacks, strokes, and, widespread blood vessel damage compared to a typical type 1 patient.
So if this double diabetes creates this biological trap of increasing insulin and increasing weight, what happens when a patient is stuck in that trap for almost 2 decades?
It's incredibly difficult. And that is the specific crisis the subject of this case report was facing.
Right. She's a 33-year-old woman who has lived with type 1 diabetes for 19 years.
Yeah, diagnosed right at age 14.
Which means her entire adult life has been shaped by this.
Living with type 1 for 2 decades requires immense daily cognitive and physical effort.
Just constant monitoring.
Exactly. And by the time of her preoperative evaluation, her medical management had really reached a severe impasse.
Because her body mass index was 40.8.
Right, 40.8 kilograms per square meter, which places her in the category of class 3, or morbid obesity.
And despite clearly making aggressive efforts with her doctors to manage the condition, her glycemic control was just faltering.
It was. Her HbA1c was stuck at 7.4%.
Which, when your 3-month blood sugar average is hovering that high despite massive doses of insulin, the standard toolkit just isn't working anymore.
No, it's not. The burden of her treatment was staggering.
I want to dig into how she was taking that insulin because the report breaks it down, right?
Yes, she required extremely high doses, but it's important to look at how it's divided. Diabetics generally use 2 types of insulin management.
Okay, let's break that down for the listener.
Sure. So first, there's basal insulin.
Which is the background insulin.
Right. It's the slow-acting insulin you need constantly just to keep your liver from dumping stored glucose into your blood.
And then the other type.
The other type is prandial insulin.
The mealtime dosing.
Exactly. The rapid-acting shots you take specifically to cover the metabolic load of the food you're about to eat.
Okay. And for her, those prandial doses were just massive.
Her prandial insulin requirements were enormous, which reflects just how resistant her tissues had become to processing that immediate influx of nutrients.
And alongside all of this, she's managing a whole cascade of secondary issues, right?
She was. She presented with hypertension, dyslipidemia, meaning abnormal lipid and cholesterol levels, and an active smoking history.
I mean, just imagine trying to balance a highly complex chemical equation in your body every single time you sit down for a meal.
It's exhausting.
You calculate the carbohydrates, you inject the rapid-acting prandial insulin, but the underlying machinery, your own cells, is actively resisting your efforts.
Yeah.
You do the math perfectly, and it still fails.
The physical and psychological toll of that daily reality just cannot be overstated. Standard medical therapies were no longer sufficient to break the cycle.
So she reached a tipping point.
She did. And that triggered a rigorous, multidisciplinary evaluation involving endocrinologists, surgeons, and dietitians.
And their consensus was to proceed with a laparoscopic sleeve gastrectomy.
Correct.
So let's look at the mechanics of the surgery itself. It's minimally invasive.
Right.
The surgeons go in, remove a large portion of the stomach, and leave this narrow tube, or a sleeve.
Yeah, and on the surface, it seems purely restrictive, like you physically just can't ingest as much food.
But the underlying biology is way more complex than just volume control, right?
Oh, absolutely. It is fundamentally a metabolic and hormonal reset.
Because of the ghrelin.
Exactly.
Yeah.
When they remove that large portion of the stomach, specifically an area called the fundus, they are removing the primary source of ghrelin.
Which is the hunger hormone.
Right. It signals your brain to seek out food, and it influences how the body stores fat. So by drastically reducing ghrelin, you alter the baseline metabolic drive.
So it's not just feeling painfully full after 3 bites. The actual chemical signal demanding food is turned down at the source.
Precisely. And furthermore, the altered anatomy changes how quickly food reaches the small intestine.
Which does what, exactly?
Well, this rapid transit stimulates the release of incretin hormones, most notably GLP-1.
GLP-1. We hear a lot about that these days.
We do, and for good reason. These incretins actively improve the body's insulin sensitivity, completely independent of the weight loss itself.
Wait, really? So before she even drops a single pound, her software starts functioning better?
Yes. The hormonal shift happens almost immediately.
That sets the stage perfectly for the 6-month postoperative results, because the numbers in this report are striking.
They really are.
At 6 months, her BMI plummeted from 40.8 down to 27.2. She moved from morbid obesity all the way down to just the overweight category in half a year.
The structural offloading of that adipose tissue is critical.
Yeah.
But the metabolic transformation is the true focal point.
Right. Her HbA1c improved from that suboptimal 7.4% down to 5.8%.
Which is basically knocking on the door of a non-diabetic range.
For someone living with type 1 diabetes for 19 years, achieving a 5.8% HbA1c must feel like stepping into a completely different body.
Absolutely.
Yeah.
And her insulin requirements reflected that shift. Her total daily insulin needs dropped massively.
But let's go back to that distinction between basal and prandial insulin, because the report highlights a very specific pattern in how her medication decreased.
The authors document that the dramatic drop in her total daily insulin was driven almost entirely by a reduction in her prandial or mealtime insulin.
So her basal insulin, the background requirement, stayed relatively stable.
Yes, it stayed stable.
I'm trying to connect the dots here. Why does that specific reduction in mealtime insulin matter so much to the researchers?
It points directly to the mechanical and metabolic mechanisms we just discussed.
Okay, unpack that a bit.
Because the sleeve gastrectomy physically reduced the volume of food she could ingest at one time, and because the incretin hormones were improving her immediate insulin sensitivity, the metabolic load of eating was drastically reduced.
So she no longer needed those massive emergency brake doses of insulin every time she ate.
Exactly. The extreme spikes in blood sugar were being mitigated by her altered digestive anatomy.
The surgery specifically optimized how her body handled the biological stress test of eating a meal.
It did. And the systemic benefits cascaded rapidly. Her blood pressure normalized. Her lipid profiles improved.
The entire cluster of cardiovascular risks that were threatening her long-term survival began to de-escalate.
Yes, it's a profound cardiometabolic improvement.
We also have to talk about what didn't happen here.
Right, the safety profile.
Because the report explicitly notes there were no episodes of diabetic ketoacidosis or DKA.
Yeah, and no severe hypoglycemia during the follow-up either.
So why is DKA such a specific fear when you're doing bariatric surgery on a type 1 diabetic?
Well, DKA is a life-threatening complication. It happens when the body lacks sufficient insulin to utilize glucose, so it rapidly breaks down fat for energy.
Which produces those acidic byproducts, the ketones.
Exactly. If ketone levels build up, your blood becomes dangerously acidic.
And bariatric surgery involves a lot of fasting and surgical stress, right?
Yes, plus a drastic post-operative reduction in caloric intake. In a type 2 diabetic, the body still produces some insulin to act as a brake on that ketone production.
But a type 1 diabetic has zero endogenous insulin.
Right, so the physiological stress and the rapid fat loss from the surgery can very easily trigger this runaway train of ketone production.
So the fact that her medical team navigated her through that intense metabolic shift without triggering DKA or causing severe low blood sugars is a massive victory for the safety of the procedure.
It demonstrates that with meticulous, specialized, multidisciplinary management, the perioperative risks can be controlled.
Okay, here is where I need to play devil's advocate for a second.
Please do.
It's easy to read these results and just declare the surgery a total triumph.
But there's a major caveat.
Exactly. Alongside the surgery, the patient made significant lifestyle changes.
Right, she quit smoking and she increased her physical activity.
So if she fundamentally changed her habits, isn't it scientifically irresponsible to publish this as a win just for the surgery?
Well, that is the exact critical lens we have to apply here.
Because how do we know the improved insulin sensitivity wasn't just from hitting the gym and putting down the cigarettes?
We don't. And the authors of this Care Compliant report, they don't hide from that reality at all.
They walk right into it.
They do. Because this is a single patient case report with a relatively short 6-month follow-up, it is scientifically impossible to draw a definitive, isolated causal line.
Right. I mean, we know smoking cessation improves vascular health and blood pressure within months.
Absolutely. And physical activity forces muscles to consume glucose, which increases insulin sensitivity.
So those factors undeniably contributed to her reaching that 5.8% HbA1c.
Yes, they did. We can't put her in a time machine, create an alternate version who gets the surgery but keeps smoking, and then compare the two.
We can't. The variables are just hopelessly entangled in a single case study like this.
Which leads to the natural question.
Right. I mean, if we can't definitively say the surgery did the heavy lifting, why put it out there? What is the value of publishing the report in a peer-reviewed journal like this?
Well, in medicine, observation has to precede optimization. A care-compliant report like this functions as a high-visibility signal flare. It's a proof of concept.
So they aren't claiming that every type 1 diabetic struggling with obesity should just be rushed to an operating room tomorrow?
Not at all. They're demonstrating that in a carefully selected patient, under intense supervision, metabolic surgery can disrupt this seemingly inescapable cycle of double diabetes.
It changes the conversation from, we shouldn't risk this because it's uncharted territory to look at what is possible when we do.
Exactly. And that brings up the institutional and policy implications.
Oh, right. Let's get into that. How does this affect the actual systems in place?
Right now, health policy and insurance guidelines for bariatric surgery are almost exclusively designed around type 2 diabetes.
Because that's where all the massive data sets are.
Right. So for a type 1 patient, getting an institution to approve a sleeve gastrectomy can be a massive administrative battle.
They just hit a wall of
A wall of red tape, exactly. Insurance providers might view it as experimental. So a structured, rigorously documented case report provides the medical community with peer-reviewed precedent.
It gives them leverage.
Yes, it signals to hospital systems and policymakers that we need to start reconsidering those rigid policy barriers.
It provides the clinical justification to fund and design larger prospective studies.
We need trials that track hundreds of patients over 5 or 10 years, utilizing control groups to isolate the surgical impact from lifestyle changes.
And we need to understand the long-term durability of these metabolic improvements, right?
Yes, and the long-term nutritional risks for type 1 patients who have altered digestive tracts. This case report is the catalyst for that necessary research.
It is the spark that lights the fire for the next decade of endocrinology research. I appreciate you walking through the biology of this with such clarity.
My pleasure.
Untangling the mechanics of gut hormones, exogenous insulin traps, and surgical interventions really reveals just how complex the human metabolism truly is.
The landscape of diabetes management is evolving rapidly, and rigorous observation of outlier cases like this one forces the entire field to rethink its assumptions.
Before we wrap up this deep dive, there's a broader system-level reflection here that I want you, the listener, to mull over. We have spent this time analyzing a patient with type 1 diabetes who required a treatment classically reserved for type 2.
Right.
The surgery didn't cure her underlying autoimmune disease, her pancreas still doesn't produce insulin, but altering her digestive anatomy fundamentally changed her body's relationship with the insulin she injects.
It mitigated the insulin resistance we usually associate entirely with type 2.
Exactly. So if physical interventions can so drastically alter the metabolic reality of a disease, how much of what we classify as strict type 1 or type 2 might eventually blur together?
It's a fascinating question.
Are we moving toward a future of medicine where we stop treating the broad historical label attached to a patient's chart and instead start designing dynamic treatments for the exact, unique metabolic profile of the individual sitting in the exam room? Keep questioning the boundaries of what we think we know and keep looking for the underlying mechanisms. Thank you for listening to the GMJ podcast. For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal. A direct link is provided in the episode description. We look forward to continuing these scholarly discussions in future episodes.